First of all, a very good morning to all of you, participants as well as listeners. And I thank you all, everybody, for giving me an opportunity to present myself with the impact of COVID-19 on medical practice. Being
video.
I will be presenting an anesthesiologist perspective only. You want video also? You want
Hello?
video?
No, sir, no.
No. Okay.
You can carry on, sir. Please
Yes.
proceed, sir.
The speakers who spoke earlier made it easy, and there is no need to go into the details of what COVID-19 is, what are the causative agents and origin and all that. What I would like to say that this is totally unprecedented situation our generation is facing, because generation previous to us, or I hope the next generation should also not see such calamity. I would like to clarify a few things before I go to the details, because they were not covered. We should, I think many non-medicals are also listening to this conversation. So it is, there are a lot of medical terms in our presentation, and they may not understand these terms properly. I will try to make these things as simpler as possible for all of them. So we must know few terms before we go to what is pandemic and epidemic and all that. A disease is said to be endemic when it is restricted to a particular region or a country and is there for a long time, or is not leaving that particular area. It is in a form of continuous disease. For example, malaria is endemic in Africa. When the endemic disease is outbreak is when we get number of cases more than anticipated or expected. Unexpected or unanticipated endemic turns into the epidemic, where the large number of population, community or country is involved. And then an epidemic is uncontrolled, it gets converted to a pandemic. So what is pandemic? Pandemic is epidemic with P. And P stands for passport of epidemic to travel to all other countries as well as to all other continents. And an uncontrolled epidemic becomes pandemic, like COVID-19 has become. What is COVID-19 stand for? What does it stand for? So CO stands for corona, VI for viral, and D for disease. Since it started in 2019, the 19 stands for that. As you all know, it started from Wuhan, a second grade city in China, in a form of endemic, getting uncontrolled to epidemic, and then got caught the whole world. Today, the spread is intercontinental and all over the world. As many as 212 countries are under the stress of COVID. If you talk about the infectivity, more than 4 million people have already been affected and more than 2 lakh people have succumbed to the disease. It is said that the mortality of the disease is less, 2.5%. If compared to the previous diseases like SARS, it was 9.6%, MERS, it was 34.4%, and H1N1, 17.4%. But then, what is the point of concern this disease is making, and why this is so outstanding among the all diseases which has previously been seen? Because this is an infection, this is the infectious disease which spreads through droplets and aerosols to the healthcare workers as well as to the general population. Again, I would like to define what is droplet and what is aerosol. Droplet is a very small particle. It is a part of a drop, therefore droplet. And still smaller, a globular form of droplet is aerosol. Droplet may be visible, but aerosol may not be visible. And it is this invisibility that causes the spread, and that is troublesome, and we can never know how the disease is spreading. By the time the symptoms appear, By the time the patient is sick, it is too late because the patient is invaded by severe infection. The second problem is that this disease presents with varying grade of infection, and the course is also very different for different people, depending upon the immunity and many other factors. You may see a totally asymptomatic patient without any symptoms, prodromal symptoms, which are very cardinal of the disease, like fever, cough, shortness of breath, or anosmia, what has been described in book. The totally asymptomatic patient may be presented, and you never know that he is a carrier. Or you may be at the opposite end, you may get a patient who is severely infected, needs all sorts of gadgets and expertise and to be treated in ICU, and despite that may succumb. So this is the wide spectrum of grade and course of the disease and infection, which makes it very terrible. The third factor which contributes to the differentiality of the disease is that there is no definite or specific treatment available till date. Neither there is vaccine developed till now. So these two factors add to the severity and spread of the disease and make people more vulnerable to it. Moreover, the tests which are available to detect the disease are restricted to only few centers and cannot be, like Dr. Bora said, that South Korea has tested almost all the population. We in India, with the bulk of 135 crores, cannot go for that, and it is simply impossible for us. So that is another hurdle in controlling and diagnosing the disease at an earlier stage. Last but not least, the preoperative test reports, like in case of AIDS, an HIV report is available. In case of hepatitis B, Australia antigen test is available. In case of malaria or in tuberculosis, the tests are available. So when a patient comes for surgery, these tests are already routinely done, and you are aware of the diseases or the comorbidities the patient is presenting to you with. But this cannot be the case with COVID-19, and this is again a difficulty to tackle these patients. So how to tackle the problem then? Because the problem has occupied the whole world and we have to now tackle it. There is no alternative, no other go. What can be done? As an anesthetist, I will be covering only my anesthesia purview, and I will be restricting myself, but I may go little here and there, because it's not only, anesthesia is only a part of the whole system. It's not the full answer for the problems to be tackled. So as an anesthetist, what can be done? We can, now if the surgical procedures are to be, as far as they are concerned, they can be divided into two major groups: the electives and the emergencies. I will define this. Elective surgeries are those non-urgent surgeries which can be fixed by the convenience and consent of both surgeon as well as the patient. They may be postponed, they are not life-threatening, and they are not emergent. On the other hand, emergencies are life-threatening. They can again be classified into ultra-short and semi-emergencies. The dire emergencies are those where you do not get time to prepare yourself and your system. You have to deal as it is. The situation is like that. For example, an emergent cesarean section with hand prolapse. This is medical term, but this is such an emergency. You get no time. You take no time to prepare or think. You have to proceed with it because two lives are in question, mother and a baby. So this is the most dire emergency at one end. And there are few emergencies wherein you get few hours to investigate the patient, optimize the conditions, and then detect them. So these are semi-emergencies. So in the present scenario, what we can do to tackle the problem is to go for only emergencies and should not focus on elective surgeries. So that will reduce the bulk of the pressure on the medical workers, and that will also restrict the number of cases which are positive of the spread of the disease by itself. Now, before admitting the patient and exposing him for surgery and preparing for any procedure, few things are very important, like history taking. As in all other cases, history taking is of vital importance in COVID patients. Is there any history of travel, international travel? Though the incubation period of this disease is by and large over, this point was needless to be put in this slide. But since Vande Bharat program has been started by Government of India, wherein those who are entangled at other countries are now being brought back to India, to their motherland, and now they will be traveling, and therefore again they will have to undergo quarantine and isolation. Therefore, the history of travel is very important. Out of the fear, patient may hide this history, but you have to take that as a point. Is there any history of contact with COVID positive, that is lab proven COVID positive patient, or there is a suspected patient wherein the symptoms are present? They are also to be monitored. At the entry of the hospital, a simpler, see, we have to be very cost effective as far as our country is concerned. So what we can do as a simpler measure, as the least expensive measures, we can do 2 tests before admitting the patient right at the door of the entry. We can do his thermal testing, and we can go for his oxygen saturation by a disposable or reusable pulse oximeter. So if these 2 things are done at the onset, we may prevent many patients who are positive or who are posing risk to the health workers, and we can minimize the stress of infection to be spread. Then we have to take the history of comorbidities. What are comorbidities? The word itself means co and morbidities. The existing diseases which the patient is presenting with, they are already with the patient apart from that COVID possibility or COVID proven. So what are they? This disease is affecting particularly 2 groups of patients. Those who are senior citizens, means more than 60 years of age, and those who are not of that age but presenting with existing comorbidities like diabetes, hypertension, pulmonary vascular disease. Those patients who are immunologically suppressed, maybe because of chemotherapy, maybe because of malignancy, maybe because of other diseases. So in these patients, these are the target of COVID, and therefore this history is also relevant. And at the last, before admitting the patient, the basic symptoms like fever, cough, usually dry, absence of smell sensation, that is anosmia, and malaise, they have to be taken into consideration, and then only after screening the patient has to be admitted. Now, how to deal with the emergencies? As already told, we have now focused ourselves only on emergencies, emergency surgeries. So how to focus on how to deal with these cases? Consider only life-saving emergencies and semi-emergencies that I already told. Now, as far as the technique of administration of anesthesia is concerned, again, this can be broadly divided. Anesthesia is a procedure wherein there is a reversible loss of consciousness of the patient, or at least we alleviate the pain of the patient of the surgical procedure. And therefore, this anesthesia can be divided broadly into 3 categories: the local anesthesia, the regional anesthesia, and the general anesthesia. The local anesthesia is a technique wherein a small part of the body, like something you have to take 2 stitches on the forehand of the patient or 2 stitches on the forehead of the patient. You need not anesthetize the whole body of the patient, and you give a local anesthetic to the restricted area, thereby alleviating the pain and making the procedure pain-free. Second is regional anesthesia, wherein the anesthesia is restricted to a part of body like upper limb, only lower limbs, lower abdomen and lower limbs, and something like that. This can be achieved by different blocks, or spinal anesthesia, or epidural anesthesia, or a combined technique. And the last is general anesthesia, where the patient's whole body and consciousness is, he is deprived of his consciousness for a short while, which is reversible. And for administering general anesthesia, you have to go for many number of times, more than often. There are other techniques which do not necessitate the intubation or the supraglottic airways, but more often than not, you have to handle the respiratory tract of the patient. The basic difference between the regional anesthesia techniques and the general anesthesia is that you never have to go for handling of the respiratory tract of the patient under regional and local anesthesia. But while administering general anesthesia, you have to handle this. Now, this is the crux of the problem. Once you do laryngoscopy, which is a procedure of putting an artificial tube in the windpipe or the trachea of the patient, you have to handle the oral cavity. There are a lot of secretions, and because of the handling itself, patient has got high chance of coughing, and coughing itself will generate lot of aerosols and droplets, which are the source of spread of the disease. So that has to be avoided. So, in under nutshell, you have to go for regional anesthesia techniques as a part to deal with the emergencies of COVID. Then there is I have already mentioned that there are secretions because of the procedure itself and because of the anesthesia itself. And these secretions in the oral cavity in and around the respiratory tract, they have to be suctioned. Now, what is suction? Suction is creation of a negative pressure using a Venturi principle by a device, which may be manual, electrical, and at the end of that arm, there is a catheter with a whole eye, and that is put around the secretions to absorb them or to just suck them out. This again is a procedure which involves lot of aerosols or droplets to be created. Naturally, the risk of spread is there. While doing, I have already talked about laryngoscopy. It is a procedure wherein you put a scope inside the oral cavity of a patient to visualize the respiratory tract opening, that is vocal cords, wherein you put the tubes. And you are at a distance of less than 12 inches to the patient's oral cavity and respiratory tract. See, the situation is grim. The anesthetist is just about a foot of distance, less than even 12 inches, and is facing that patient who is unknown to him whether he is positive or not, suspect or positive and all that. So this can be avoided by use of video laryngoscopy, where the view of all these structures is displayed on the screen, and you can handle it from a little longer distance, and therefore the risk is reduced. And therefore, the techniques like fiber optic laryngoscopy or awake intubation, which is usually done in critical care units or in casualty section, they are to be avoided for the same reason, because they generate lot of droplets and aerosols. It is a routine fashion in critical care. Those who are working in that unit must be agreeing for this, that they are used to intubate the patient, that is by a technique called as awake intubation, which does not usually use the muscle relaxant. But while tackling such difficulties, even in those areas like critical care or casualties, it is advisable to use muscle relaxant for intubation if at all it is needed, because that will uptune the cough reflex and thereby the severity and the spread of the disease. What other precautions are to be taken if general anesthesia administration is unavoidable? There are situations where regional anesthesia fails, or for some other reasons, like a trauma which cannot be covered in the regional anesthesia. You have to proceed with the accident patient, say with the injuries of head, neck and face, which cannot be covered by regional anesthesia. So you may be required to go for general anesthesia, which is unavoidable. So what can be done in these situations? Give a proper pre-medication. What is pre-medication? These are the drugs which are given before starting the procedure of anesthesia to reduce the secretions, that is anti-sialogogue drugs. The drugs, antiemetics, which reduce the chances of vomiting, and also the drugs which obtune the cough. They have to be pre-oxygenated, means they have to be administered oxygen on mask for a longer time than usual. It is a flow of more oxygen for a longer length of time to combat that apnea phase. The proper technique, as already told, is there should be smooth induction and intubation, no bag and mask ventilation, which is usually done in a routine patient. So that has to be varied. Avoiding cough and vomiting, no auscultation. Auscultation is a method where you check the entry of the gases into the lungs by putting a stethoscope on the chest of the patient, has to be avoided since you come in close contact, and that can be alternatively done by using multi-parameter monitors with ET/CO2 recordings. An intubation box, which is now invented by many forms of the same are being used at different institutes across the India. They can be used. They are the barrier to be placed, transparent barriers placed between patient and anesthesiologist to avoid the droplet to infect anesthetist. And the simple rules like inflating the bulb of the endotracheal tube, clamping the tube before extubation, and disconnecting the circuits, these can be followed to avoid infection. And the list of the things to be avoided can be shortlisted. Avoid high flow devices, nebulization, awake and fiber optic intubation, Antonox or inhalational sedation, bag mask ventilation, non-invasive ventilation, use of T-piece or any other open anesthesia circuit. Do not suction frequently and do not use open suction unit if at all needed. Use minimal closed suction units. In fact, do not use the infected breathing circuits, and most importantly, avoid overcrowding inside the operation room. The other safety measures like use of PPE, personal protective equipment, which consists of hood with head cover, goggles, face shield, N95 mask, all over woven water-resistant surgical gown, double gloving, and a foot cover up to the knee. These are the parts of that PPE. There are various parts. The use of the circuit filters to avoid anesthesia machine getting contaminated. The filter is placed in the expiratory arm of the circuit. The closing suction line, the thorough aseptic precautions more than usual have to be taken, and the most important, proper disposal of the used material, because these used materials are infected and may cause the spread of the disease. So they have to be disposed absolutely methodically and meticulously. As already stressed, the OT should be attended by minimal number of people. What is post-COVID-19 scenario? How long this COVID is going to last? This is $1 million question which everybody wants to ask, but unfortunately we don't have answer of this. The answer remains uncertain. Till the time the definitive or specific treatment or the specific drug is invented, or the vaccine comes out, or the herd immunity develops, that means the most of the or the bulk of the population has developed, is exposed to the disease and develop the immunity by themselves, or the virus undergoes mutation to a lower virulent form. But this will take time, and as per the experts, the time may be somewhere from 6 months to 2 to 2.5 years. So we have to live with the disease, that is COVID. We have to change the lifestyle. We have to adapt the COVID culture. What is COVID culture? It is the amalgamation of the following facts, like social distancing, keeping the distance of around 6 feet and more, avoiding social gatherings for whatever purposes like marriages or other ceremonies, maybe for political or social causes, maybe for educational causes like conferences and all that, they have to be avoided. Frequent hand wash, as already told by first speaker, 30 seconds of wash with detergent or soap. Generalized cleanliness and sanitization as covered by Dr. Bora. Use of face mask as already told. Covering face with while sneezing and coughing. A small hint can be given over here that it is advised to use the shirts with longer or full sleeves, and to develop a habit of sneezing at all if you cannot avoid it, to sneeze on flexed elbows which are covered by full sleeve shirts, so that the droplets or the aerosols are absorbed and are restricted to the clothing of the person and do not spread. The general and the personal hygiene has already been covered. Unnecessary habit of touching face has to be avoided. Overcrowding has to be avoided, and unnecessary traveling, casual traveling without much of purpose, that has also to be avoided for nearly 1 year from the date. India has given many systems to world, like yoga, which is now being celebrated all over the world as a yoga day in June. Similarly, the Indian system of Namaste by folded hands up, just below the face and above the chest, that is being adopted by the whole world instead of that handshake. So that is a better method to prevent. Then living with COVID also makes you to have inculcate yourself with few healthy habits, like healthy and nutritious food intake only. Avoid uncooked, half-cooked or ready-made or junk food. Do regular exercises. No need to go to gyms. Again, you can adopt Indian methods like yoga, asanas, pranayama, meditation, which can be done in a corner of home, which can be done alone, which can be done without any instrumentation and props, and which are very inexpensive. lastly, they can be done at any time of the day as per their convenience. And moreover, these are not the physical trends only. They cool your brain, they calm you, because all diseases basically originate. It's a mental game. All diseases, according to Ayurveda, begin in the brain. They are mental first and then physical later. And therefore, these will enhance to your lives. This put together to your life as a habit would enhance your quality of life. Therefore, the elective surgeries, as already covered, till then, stay home, stay safe, be strong, and do not panic and do not spread panic around you. Antatah, सर्वे तु सुखिनः सन्तु, सर्वे सन्तु निरामयाः, सर्वे भद्राणि पश्यन्तु, मा कश्चित् दुःखमनुष्यात् भवेत्. COVID once again reiterated the truth of the fact that life is simple and easy, but made complex by lifestyles. Quarantine, lockdown, and isolation has given us time to introspect ourselves, to redefine ourselves, and to know the purpose of life, to be with the family, to be united. So that is a silver lining to the cloud, with dark cloud of COVID. I would like to finish my lecture with this. The session is open for question answers. Thank you.
Thank you, sir. Thank you so much, sir, for providing that silver line to the black clouds of the COVID-19. Thank you, sir, for your role as wounds without pain. Thank you for guiding us with the minute details of COVID-19 and giving us the insights through your perspective. Thank you so much. We'll move ahead with the question answer session now. Shall I read the questions, sir?
Yes,
Hello.
Yes.
Yes. So, one of the questions from Mrs. Manisha Rajput, that we have heard about the plasma therapy. So, is it a successful, and if yes, what is its success rate?
See, it is under trial, and some time has to be given for the results to come out, and then to authenticate it. But it is under trial, and it may prove to be useful in coming future.
Okay, sir. The next question is from one of the students, that why is it taking so much time for the COVID positive test results in spite of kits like MyLabs are available?
No, it is basically the non-availability of the kits itself. And the car test, there is a high chance of up to 30% chance of false negative. So therefore, they are not of much use. And the tests are not being done routinely because of the unavailability of the kits itself. Once they are available, time can be reduced.
Okay. Thank you, sir. The next question is from Dr. Mukund Chaudhary. The spread of COVID is more in European countries as compared to the Asian nations. Does it mean that Asians have more average immunity?
Yes, that's a good question. See, COVID is not the only viral infection we are facing this year. We had faced many other viral diseases in last decade, as many as 4 to 5. And so we are exposed to these sorts of diseases quite often, and therefore we have got an inbuilt immunity against these infections, maybe a cross type of immunity, and we are used and tuned to these diseases more than the European pattern of living. Therefore, our immunity definitely works, and these people like European or American who have very low immunity against this, they succumb a lot as compared to any Asian country or Indian subcontinent as such.
Okay, thank you, sir. The last question we'll take. In rainfall session, COVID-19 may be critical for society or not? What is your opinion, sir? Pajwardhan Patil, sir. In rainfall season, COVID-19 may be critical for society? Hello? Am I audible, sir?
No, I could not get speed.
In rainfall season?
Yes. Maybe little increase in the number of cases, because the dry heat is helping in two ways. It is somehow helping in not spreading the disease. Secondly, whatever linens and other equipments we are using and reusing them, they get dried up quite soon. There is no humidity also. Humidity may be a factor which may lead to the little extra growth or probable growth of the viruses. That is not true, but maybe.
Okay. Thank you, sir. Thank you so much for being with us this morning. We are really honored to have you as a speaker. May I now request Principal Vadai sir to
Thank you very much, organizers,
express.
and giving me an opportunity to be with you and sharing my views as an anesthetist. I'm really thankful to you. Thanks. Thanks very much.
Over to you, Principal sir.
Yeah, thank you, Dr. Surendra Mundhada sir, for elaborative explanations, specifically with respect to the pre-surgery and during the surgery, the care what need to be taken. And I know that the job of anesthesians are very, very critical because they have to be very close to the patient during the various kind of the treatment. And your explorations and presentation was very awesome. Thank you very much, sir. Over to Trupti.
Thank you, sir.
Thank you.